Hello, everybody. Welcome to our event today on palliative and hospice care. We are happy at the Institute for Human Ecology at the Catholic University of America to be co-hosting this as our first collaboration with the National Catholic Bioethics Center. The National Catholic Bioethics Center provides education, guidance, and resources to the church and society to uphold the dignity of the human person in healthcare and in biomedical research. The Institute for Human Ecology exists to educate university students to give, quote, the Republic her best citizens, to sponsor multidisciplinary academic research on the intersection of human flourishing and Catholic social doctrine, and to organize events encouraging conversation between the academy and the public square, such as this one. I am the director of the program in human rights at the at the Institute for Human Ecology. You might ask, what does human rights have to do with bioethics? And the answer is everything. I actually have been involved in issues of bioethics, particularly since the stem cell research and cloning debates around the year 2000, and I am proud to be an affiliated scholar with the Pellegrino Center at Georgetown Medical School. One of our speakers is Myles Sheehan, who from the Pellegrino Center, who I'll introduce in a minute. And I also write a regular column for the National Catholic Bioethics Quarterly, where our other speaker is an ethicist. So let me introduce, the second thing though I wanted to mention is for human rights, I have a Master of Arts in Human Rights program, and one of our required courses is bioethics. So the issues around the dignity of the human person sometimes can be described in multiple ways, but in my view of human rights, an essential part is bioethics. So let me introduce our other speakers. Myles Sheehan is a Jesuit priest, physician, and professor of medicine. He joined the Georgetown University Pellegrino Center for Clinical Bioethics and the Georgetown Jesuit community in January 2020. Father Sheehan was ordained a priest in 1994. For 14 years, he worked at Loyola University in Chicago, first as a professor and eventually as senior associate dean at the Stritch School of Medicine and the Ralph P. Leshner Professor and Chair of the Leshner Institute for Medical Education. Father Sheehan teaches Catholic clinical ethics and serves on the Ethics Consultation Service and Ethics Committee at MedStar Georgetown University Hospital. Our second speaker, Jozef Zalot, joined the National Catholic Bioethics Center as a staff ethicist in July of 2017. He served from 2015 to 2017 as the Regional Director of Ethics and Spiritual Care for Mercy Health, Cincinnati. During this time, he also served as a lecturer at the Athenaeum of Ohio and Mount St. Mary's Seminary. From 2004 to 2015, he was a tenured professor at Mount St. Joseph University in Cincinnati, where, among other things, he taught courses in healthcare ethics. The other thing I'd like to tell you before we get into our topic is how you can ask questions. I'm sure you'll have a lot of questions. You can submit your questions by the Q&A box, and we'll get to as many questions as we can in about 40 minutes or so. So briefly, just to introduce the topic, I mean, at this time of the COVID pandemic and what our whole world, but also our country has suffered under for the last year, it's drawn people's attention, I think, to healthcare ethics. And we thought it was a particularly good time to talk about the Catholic approach, and particularly to palliative care and to hospice care. So there's a lot of confusion and uncertainty around some of that. So we're going to start off with Myles. is going to give us a presentation to help orient us, and then we'll get into discussion first with Joe, and then we'll open it up to others. So Myles, give it to you.
I'm hoping to share my slides with you now. And can you see that? Great. And so let me get to the beginning. All right. As Bill had mentioned, there can be a little bit of confusion about some of the different terms we use. So this relatively brief presentation, I hope, will help a little bit with that. Just by way of my background, I'm trained in internal medicine and geriatrics, and I did a lot with working in palliative care, although I never was certified in it. My palliative care experience was mainly with my older patients. And so let's see where we go from here. And what I hope is that we can come up with the difference to understand what palliative care is, as well as hospice care and the difference and overlaps between the two. I'd like to clarify some of the teaching on end of life and palliative care that have come from specifically John Paul II, as well as the Ethical and Religious Directives, which is a document approved by the U.S. Conference of Catholic Bishops and the Congregation of the Doctrine of Faith that governs Catholic healthcare in the United States. Now, the next few slides, it's more than slide, the next 4 slides, I am taking out of what's called the Education on Palliative and End-of-Life Care curriculum, which was developed about 15, 20 years ago in Chicago out of Northwestern University. And I've worked with those people and came up with a Catholic version of ethics. So they let me use their slides. And what I'd like to start off with is 3 slides that talk about the trajectory of dying. Now, less than 10% of us are going to die suddenly. And that's what this slide attempts to show. With the top black line, you're cruising around and then something sudden happens, whether it's an accident or a massive heart attack. Obviously, palliative care and hospice is not an issue in those situations. With this slide, and this is the kind of dying process that you might see in an individual who has either an untreated cancer or a cancer that recurs after treatment, where the person, in terms of their health status, their function, they're doing okay, but then it comes a time when they decline. They're not able to get around as much. They finally end up in bed. This, again, would be the thing that you would see with a malignancy that perhaps was not treated, or with someone who had previously been in remission, but the cancer recurred. The third slide here is one that is probably the most important, but in some ways the least intuitive, because it deals with how a large portion of us die or will die. I presume will die for everyone who's watching today. And what it shows with the jagged line is that these are people who are usually elderly. They might have a dementing illness such as Alzheimer's. They might have heart failure. They might have emphysema or COPD. So that what you have with these little dips are crises where someone will show up at the hospital makes them feel better. They go back, but they're still not doing well. And it can be difficult to tell sometimes that the person is dying along the way. What makes you think recurrent hospitalizations for an underlying condition that can no longer be effectively treated or reversed. Now, this is a very fancy slide, which I could never make on myself. And this sort of shows the situation back when I was a medical student. I graduated in 1981, and hospice just came as a benefit towards, I think, around 1980. And so someone would show up, say, with cancer, and what would happen is very aggressive treatment would be given until the last few days or weeks, and then, well, it's time to go to hospice. That seemed to miss a lot of the problems that could happen along the way. As you see that shaded line, where a person can be treated with curative therapy or treatment aimed at inducing a remission from the illness. But again, the person is experiencing increased burden from the illness. They're sick, they are suffering, etc. Palliative care has been developed as a way in which we can care for people prior to the hospice setting. Now, the word palliative comes from the Latin meaning pallium, a cloak or a shelter, and it's not equivalent to hospice care. One can combine palliative care with curative care, and it attempts, as does hospice, to address suffering in all its dimensions. Hospice has a number of different ways to look at it, but basically it focuses on pain and symptom control directed to people who are likely to have less than 6 months of life. And a hospice can be a physical location, or it can be a care team that provides in-home assistance, or it can also be a way that you describe a philosophy of care. It is covered by Medicare and many insurance benefits. It usually does not provide curative treatment or hospitalization. And again, what hospice does is use palliative care in a way directed in the last weeks of someone's life. And again, efforts at curative treatment and other things like that are no longer continued. Both palliative care and hospice look at suffering and pain and attempt to control that, the physical issues, the pain and symptom control, but also to look at some of the problems that happen socially with a serious or life-limiting illness, the isolation, the loss of relationships, the decreased ability to care for self, the psychological burden that can occur, both the loneliness, the anxiety, and the possibility for depression, and then the spiritual, the uncertainty, the why is this happening to me? Perhaps people have feelings of guilt or apprehension, or they just might be scared of facing the end of their life. Now, as Catholics, preparation for death is an essential part of what we're supposed to do, and it should be an essential part of Catholic healthcare. And it really is something seriously wrong to avoid and not to pay attention to. And if you don't pay attention to end of life, it creates needless suffering, not only for the person who's avoiding it, but also for their family and friends. Palliative care and hospice can be an important part of appropriate care for the seriously ill and those at the end of life. John Paul II, in his encyclical Evangelium Vitae, said, "Life on earth is not an ultimate, but a penultimate reality. Even so, it remains a sacred reality entrusted to us." So again, for us as Catholics, life on earth is not an absolute value. Our absolute value is our destiny, which is eternal life with God. For those of you who remember the Baltimore Catechism, who made you? God made me. Why did God make me? To know him, love him, and serve him, and to enjoy eternity with him in the next. So our ultimate goal is eternity with God, not on endless medical treatments. And again, speaking at a hospice in Vienna, the Holy Father in 1998 said both the artificial extension of human life and the hastening of death, although they stem from different principles, conceal the same assumption: the conviction that life and death are realities entrusted to human beings to be disposed of at will. It must be made clear again that life is a gift to be responsibly led in God's sight. So in other words, John Paul II is speaking at two different approaches to the end of life. Those who would take life with euthanasia-assisted suicide, obviously that's wrong, but also those who would aggressively treat when there is no realistic expectation of a positive outcome. Again, to look at why we feel this way, we pay attention to the goal of our human existence. That is the fullness of life and sharing the life of God. And that our vocation is a supernatural vocation that reveals the greatness and the inestimable value of human life, even in its temporal phase. Just to talk a little bit and quickly about the ethical and religious directives I mentioned about where they come from, they emphasize care for the dying, pain control, and caution about technology, particularly in Section 5, which deals with care at the end of life. And in the introduction, they talk about the importance of Catholic health institutions dealing with the process of dying, and also emphasizing that one of the primary purposes of medicine, caring for the dying, is the relief of pain and suffering, and effective management of pain in all its forms is critical in appropriate care of the dying. Also talks about the use of technology and to avoid two extremes: an insistence on useless or burdensome technology, even when a patient may legitimately wish to forego it. And the other hand, the withdrawal of technology with the deliberate intention of causing death. And again, the ordinary, one could talk about ordinary, extraordinary, burden, or benefit. This can get a little convoluted, but every person is obliged to use ordinary means to preserve his or her health. no person should be obliged to submit to a procedure that the person has judged with a free and informed conscience not to provide a reasonable hope of benefit without imposing excessive risks and burdens on the patient or excessive expense to family and community. To give a brief example, I am obliged to take my high blood pressure medicine because it's not that expensive and it doesn't have any side effects and it improves my health. If, God forbid, I was found tomorrow to have a widely metastatic cancer with poor treatment options, no, I don't have to go through experimental chemotherapy. The burden of that would be too high in my estimation without a great benefit. Likewise, on palliative care, again, emphasizing the importance of patients being kept free of pain, also emphasizing that one doesn't just dope them up because people need to prepare for their death and shouldn't be deprived of consciousness without a compelling reason. And then a statement here of what we call in ethics, the principle of double effect. Occasionally, one can treat pain, and in a dying person, it might indirectly shorten the person's life. If your goal is to treat the pain and not to hasten death, that is allowable. So the key points, one of the purposes of medicine is care for the dying. Effective pain control and relief of suffering is crucial. Technology must be evaluated, not used blindly, and one avoids over-treatment or deliberate killing. And finally, John Paul II, in a speech just a few months before he died, 5 months before he died, he talked about the importance of palliative care and saying that methods of palliative care are required in those stages of illness when there's no longer proportionate effective treatment and to treat suffering. And finally, he says that, the importance of making palliative care available, ideally using a team. So just to conclude, palliative care is care we use for people with serious or life-limiting illnesses. Hospice, again, is in the final stages of illnesses. Palliative care can use curative therapy, as you see what's going to happen. Hospice, usually one does not admit to the hospital or treat otherwise except to relieve suffering. So death is inevitable, and we got to prepare for that as part of our tradition. Palliative care and hospice, again, are methods to provide care. Well done palliative care and hospice can provide proportionate and appropriate pain and symptom control while avoiding burdensome and disproportionate treatments. Care that appropriately uses pain and symptom control is approved by authoritative church teaching. And having said all that, that doesn't mean that there is not the possibility of abuse or problems. I'm a big advocate for palliative care and hospice, but I don't think it always is done perfectly. Thanks.
Thank you, Myles. Thank you, Myles. So let me turn it over to Joe for some comments and questions.
All right. Actually, Bill, if we could, oops, wait a minute. I'm going to share my screen here. There we go. Can we see that?
Yes.
Yes. Yes.
So just before getting into the questions, and I have some questions for Myles to respond to, both as a physician and as an ethicist, but I did want to, if I could just take a second and shamelessly promote a relatively new document that the NCBC put out. It's been out for probably about 7 or 8 months now, but as you can see, it's called A Catholic Guide to Palliative Care and Hospice, and it's available on our NCB Center, and go to shop, and it's available right here. You can download it. As you can see, it's $250, but if people were to email me, I'd be happy to send you a copy for free. But basically, it's really kind of a summary of what Myles was talking about. So what we do in this document is define what palliative care is, give some examples of different settings and what palliative care entails. We also talk about hospice care, and you'll see this yellow part. I'm going to end with that, but talk about what hospice care is. And again, many of the things that Myles mentioned, we talk about in here, and again, it's an educational tool for Catholics. But we also, and I'm glad Myles mentioned this as well too, while palliative care and hospice can be very good, there are also cautions with it, particularly with hospice. And we identify some of the major cautions that we see. And then the guide has an insert in it that people can use, and people are more than happy or more than welcome to photocopy it. But it's a series of questions that we put together with palliative care, with a palliative care physician, as well as with a physician assistant who's very much involved in this type of work. But what are some of the questions that people should ask a hospice provider before they enroll their loved one in that hospice? And you can see, we won't go through all of the questions here. We'll see some of these issues when we do some of the questions in a few minutes. But you can see there's a whole series of questions. There's 14 questions in all, and it runs a whole gamut of various issues. And for clarity for people as they're thinking about sending or enrolling their loved one in hospice. I'd like to, if I could, and maybe put a little bow on this, and sorry if I'm giving people a headache here, I'm trying to go slowly. There's one section of this document that I absolutely love, and it's this part here that's in yellow type. And if I could just read those couple of sentences, as I said, I think it puts a nice bow on this. So the Catholic tradition maintains that a person's death is the most profound moment of his or her life. It is the moment when an individual transitions from this existence into eternity and hopefully into full communion with God. This moment and others leading up to it can be a time of great fear and anxiety. Christians have a moral duty to accompany their loved ones on the road to death and, if possible, to be with them when their earthly existence is fulfilled. And here's the money line. Hospice and palliative care provide a means to fulfill this duty. So again, in addition to everything Myles said about the good that palliative care and hospice can do, when done well, when done properly, and particularly within a Catholic perspective, they provide a means for people to accompany others on the road to their death. And that's a very profound and a very good thing. So again, this resource is available. Please feel free to go to our website and you can purchase it. Or as I said, if you would like to email me, I'd be more than happy to send it to anybody who's on this webinar today. With that being said, Bill, anything you want to say before we move into the next part?
No, Joe, go right ahead.
All right, so in this kind of second part of the presentation, I'd actually like to ask Father Sheehan at least one question. Bill mentioned before that the NCBC, one of our purposes is we do education, we do publications, but we also do consultations. So the NCBC, we field approximately 1,500 consults a year. So people will call us up and ask us questions about any issue really concerning healthcare. About 40% of our consults involve end of life. And of those, obviously, we get questions about palliative care and specifically hospice. I'd like to identify 4 areas where people ask us questions about hospice. And I'm going to ask Myles to respond only to the last one. And it's the question of nutrition and hydration. But by asking or by bringing up the other issues, I'm hoping to maybe foster a little bit of discussion. And if you looked at some of the questions from the questions to ask before enrolling a loved one in hospice, you'll see some of those questions come out here. So the first area where we get questions concerning hospice is the question of withholding or withdrawing medications for chronic conditions. I know Myles mentioned high blood pressure. It's a common one. So people will ask us, my loved one, we enrolled them in hospice and immediately they took away those medications. And so the questions that we get are, what's the rationale for doing so? And maybe more importantly, could the withholding or withdrawing of these medications be the cause of any negative or burdensome symptoms, or could it be the cause or a contributing factor to a patient's death? So that's a question that we run across. A second question we run across, as Myles mentioned, is the question of pain medication. And on one end of the spectrum, people will ask, how do we best manage pain for our loved ones? We don't want our loved one to be in pain. So how's the best way to do that? But then on the other end of the spectrum, we get calls from people who say that, we enrolled a loved one in hospice and immediately they started them on a morphine or other drip and they weren't experiencing any pain. And people are trying to figure out why did they do that and what should I do as as their healthcare power of attorney, family member, loved one? What should I do about that? A third area, we get a few issues about, not too many, but it's the assisted suicide question. So we have, I believe, 9 states, and now New Mexico just legalized assisted suicide just last week or the week before. So we have a number of jurisdictions that have legalized it, and in those states, palliative care and hospice providers, some of them, not all of them, but some of them have opted in on assisted suicide. And so what does that mean in terms of the care that they receive, the patients receive? There's a question of, can you really trust your healthcare professionals if they are advancing and promoting assisted suicide? And then again, in states where assisted suicide has not been legalized, we've had people tell us that physicians will sort of nudge, nudge, wink, wink. They'll say, when the time comes, I'll help your loved one to pass peacefully. And they kind of like, whoa, what's going on here? Or the question of VSED, voluntary stopping of eating and drinking. So these are issues these are issues that we run across, and maybe we could talk about a little bit later. But the question I'd like to ask Myles about is really about nutrition and hydration, because this is one that is, when we get consult calls, this is the issue that comes up most often. And it's a couple of things going on. So people will call us up and they'll say, hospice personnel tell us that when my loved one stops eating and drinking by mouth, they're not going to feed them anymore. And is this, what's the rationale for this? Is this ethical? Even more so, and this will be my last question, and Myles can address these. We often will get calls from people, particularly dementia cases. An adult child will call up and say, my 85-year-old mother, she has advanced dementia. She hasn't eaten anything for a week plus. She's not receiving any nutrition, hydration by medically assisted means. How do I know with moral certainty that my parent is actually going to die of their underlying medical conditions and not of dehydration and starvation? And we get that question quite a bit. So Myles, I was wondering if you could, from a medical perspective, I was wondering if you could address some of those for us.
Yeah, just after I unmute. There are a couple of things, particularly with people who are not eating or drinking in hospice. And again, I'm not talking about anybody who's trying to commit suicide. Mm-hmm. It has been my clinical experience that usually when people stop eating or drinking in the setting of a malignancy or another serious illness, it's because they're dying and they're not hungry. And no way to compare a human being to an animal. But if you've ever noticed, animals in the wild will go someplace and they don't eat or drink and they pass away. I always, always, always offer, and food, sips of liquid, soak a face cloth in bouillon, have the person that available. So to show that I am completely doing what is ordinary and required. But at the same time, again, I think it's part of how we die that we don't eat or drink at the end. The other part that's also important is that, thinking about, well, why don't you start an IV and all the other stuff? Well, the problem is that if a person's dying, the fluid's not going to get absorbed well. And there is at least the theoretical possibility that you're going to end up putting fluids in their lungs, which is going to make this worse or that. With the second situation with people who are stopping eating in the setting of an advanced dementia, again, it appears, based on what we think, but do we have absolute knowledge? No, that this is part of the dementing illness itself, and that it is possible that dehydration is the ultimate cause for the person's death, but it's so intimately related to the dementia that, again, there's no way you can treat the dementia. In these situations, again, it does require a lot of attempts to help people. Frequently in my care of people with advanced dementia, they'd stop and start. They would eat whatever you want. I mean, I have no problems with giving chocolate ice cream at 6 a.m. to somebody who hasn't eaten. But they might eat 2 bowls of chocolate ice cream and then not eat for a couple of days. I think what's hard for the family is that it's hard to see someone who's not eating or drinking. I don't think that necessarily means that we need to go and put an IV in or a feeding tube. In fact, I would not do the latter. But that what we do need to do is to try to encourage with ice chips, with ordinary ways to show that we're offering hydration and nutrition. the complication, the situation is difficult because it's so emotionally laden, as it should be.
Yeah. Just as a follow-up for that, is there any way that, and this is, and I ask this question as a means to provide some measure of comfort, as you said, that this very emotionally laden situation, and it is, but is there any way for a clinician to be able to tell physiologically whether like a dementia patient in particular is, that they are dehydrated or that they are essentially experiencing the symptoms of starvation and do something there? Or is that really not medically possible to do?
There's sort of common sense things that you can look at. I mean, if a person's mucous membranes are all dry, if you can check their blood pressure sitting up and then lying down, and if it drops a lot when you sit them up, that could well indicate that they're depleted, that they're dehydrated. Again, depending on the underlying condition, that would determine whether or not you would treat that.
Good. Bill, we're a little bit ahead of time, but do you have questions from?
Well, I do have questions. I'll give you or Myles the opportunity if you want to say anything else. One comment I'd make, which is just in relation to the issues you mentioned, Joe, about assisted suicide. From the public policy arena, I've been involved in that issue, and one of the things people should know is that there have been studies like by the British Medical Association, that when people ask for assisted suicide, almost always they are clinically depressed, and almost always, at least at the time of this study, which was about 10 years ago, most doctors weren't trained to diagnose depression, so they couldn't really, so I assume, I hope our medical training is providing doctors the ability to do that, and also to understand about palliative care, because sometimes legislatures in the states decide, on how we're going to spend money, and one way is to provide more palliative care training. So I just wanted to mention those two things in relation to assisted suicide. That a lot of times it's depressed people who are not properly diagnosed. If you're not properly diagnosed, you can't be treated, right? And doctors need to know how to do palliative care. So if you guys have anything else to say, please do. If not, I'll take some questions from the audience.
Just some of the things that Joe had mentioned earlier. I would get calls from patients when they go into hospice about changing their medications. And what I would try to do was simplify their medicine so they wouldn't have to take it 4 times a day, or something like that. If someone was on multiple insulin injections a day and frequent checking of blood sugar, I'd say let's just do that once a day, so as to, you don't need to have perfect control. It was always a very sad thing when, a wife would say, well, they stopped his cholesterol medicine. And I go, well, he's not going to die from high cholesterol. And I think sometimes some of this was the way that people were coming to grips with illness. At the same time, although I might simplify their blood pressure regimen, if they had really high blood pressure, I would continue to treat it and things like that. The idea is to make it reasonable and simple, as unburdensome as possible, and still has some benefits.
Anything else, Joe?
I was just going to mention it in light of, Bill, what you said about assisted suicide and depression. As you were saying that, I was just recalling, and I don't remember the exact numbers off the top of my head, but in Oregon, which legalized assisted suicide 20 plus years ago, and we have the best data on it. I know that over the years, or part of the protocol for assisted suicide is if a doctor believes that there are mental health issues involved, they're supposed to refer the patient for a mental health screening, if nothing else. But those numbers over the years have gone down. And I think the latest numbers is less than 5%. It may even be 2% of patients in Oregon were actually referred for mental health screening before, getting that lethal prescription. So, you're right. I mean, it's, is depression there, but, our doctors, the doctors who are prescribing these lethal medications, are they following the correct protocols? I guess that's a big question.
Let me give you an audience question. What are some legislative proposals or your own ideas that could promote home care and familial involvement in the palliative care process?
It all depends on, and I think that's the point of the question. I don't have expertise in public policy. So how one pays for this. If you have someone who is in their last weeks of life, it can be hard for you to care for that person alone because of the need to change the person, to keep them clean. You can figure that out. There is a need for assistance, whether it's from an outside person, ideally who can provide either a home health aide or a homemaker. A home health aide would do those tasks of cleaning and helping the person with their private needs. Homemaker doing laundry, cleaning, simple errands. That can be very helpful. Those are some of the things that are reimbursed at a partial rate in hospice. I think what's still hard with hospice is you are alone a lot of the time, and that can be difficult. If we could provide more assistance, that would be great. Particularly, I found hard with my older patients when there was no family except for a spouse. We often had to do hospice in a long-term care facility because it was too much for a 90-year-old husband to be taking care of the 89-year-old wife while she was dying. So again, these are things that we need the ability to have more help available, or to come up with alternative ways to look at how we do this, whether it's more inpatient hospice, which can be a more home-like environment than a long-term care setting, or other situations. Joe, do you have better ideas? Probably.
I'm not a public policy expert either, but I do echo your comments and concerns about the fact that for a lot of people, it's the family members who are the primary caregivers at end of life, and it is difficult. It's difficult physically, it's difficult financially, it's difficult spiritually, it's difficult psychologically. It is a huge burden, and how we can better do that, that's the challenge. But I don't think it's simply a political problem. I mean, it's a question of, well, I think the bigger question is, we live in a culture, it's the throwaway culture, as Pope Francis will call it. People who are elderly, we tend to put them away. And I think there's a bigger cultural shift that needs to take place in terms of, no, wait a minute. I mean, these are people, these are, human beings deserving of dignity and respect. And how can we best care for them in the final days, final hours of their lives?
Yeah, I would just say that, the breakdown of the extended family for reasons good and bad, including on the good side, maybe social mobility and people moving around, and, makes it more difficult for the family. But I would just say in those circumstances, what you need is, if you're a Catholic, and a good Catholic healthcare, the kind of things that Myles and Joe were talking about, and you need to think about those questions that Joe was talking about. If you need to put your loved one in a palliative or facility or a hospice. Here's another question. This is, I am a pediatric nurse in a largely Catholic area, but I am not myself a Catholic. What recommendations do you have for working with these families? So this is a non-Catholic nurse in a Catholic area.
I think, again, if you're working for presumably pediatric patients who are at their end of life, that, you listen carefully to the cues from the family and from the child, that you'd work with pastoral care to get insight. I think that probably in a Catholic hospital, you're aware of the importance of the sacraments as someone is approaching the end of life. and that, you know, the ability to have the chaplain to provide the sacraments on a regular basis for someone who is dying over time. I think the harder thing that is the universal experience with children who are dying is for the parents. It can seem, why? How do you answer that question? I don't have the answer to that question. All I know is that what we see, and I think it's part of the reason why Catholics, we're so heavy on our visual imagery. Our crosses have a body on it, have a corpus, and that it's part of our faith that God is with us even in these horrible moments, and that sort of sacramental sense is something that is part of Catholic culture, maybe not part of every family that's now nominally Catholic, but again, is part of what the tradition has had. Joe?
Looks like I got muted there. The first thing I'd just like to say is for the person who asked the question, Bill, you said she's a pediatric, I assume it's a she, but a pediatric nurse?
Yeah, pediatric nurse.
I remember back to when I was at Mount St. Joseph in Cincinnati, I taught a healthcare ethics course. They had an RN to BSN program, so we taught it at the hospitals, and one of the hospitals was Children's Hospital in Cincinnati. And I always told the nurses there, I said, you know, God bless you guys. I mean, you know, it's one thing to you know, be dealing with, you know, people like me or, you know, elderly people who are, you know, at the end of their lives. It's another thing to be dealing with children who are dying and are very ill and dying. And I said, you know, just God bless you guys. And they said, you know, and they always boasted that their survival rate was like 97%, but then, you know, there was 3% who didn't. And they said, yeah, it can be tough. So first off, you know, my hat's off to you and God bless you. The only thing I guess I would add to what Myles said is the person said that not Catholic, but in a Catholic area. I would say ask questions from whoever is out there. Now, whether it's, you know, if it's a Catholic hospital that they're working in or a local parish, or actually call the NCBC. As I said, we have our, you know, we've got a consultation service and we get questions, we get all sorts of questions. And so if, you know, if this person is looking for information, you know, Catholic perspective on X, or I suppose, I don't know, does the Pellegrino Center have such a thing too, Myles? I don't know.
Yeah, you can go online and send us an email.
Send an email, yeah. So reach out. I mean, the resources are there, and you know, if you have questions, ask, and you know, and we'll get back to you. And I'm sure Myles will as well.
Okay, here's another question. Can we consider chronic pain treatment a form of palliative care? And if so, what is the burden on a Catholic clinician with regard to pain management?
I think first, chronic pain is something that has to be treated seriously. And yes, there are a variety of modalities. First, to assess it. Second, to see if medication is the best way to treat it, or if there are other things like surgery or different kinds of physical therapy. And again, one can use medications. I think the concern is to make sure that you try to titrate the benefits, the burdens, to avoid a situation where the person might have a problem with dependence over time. At the same time, with a serious, clear, obvious cause for a chronic pain disorder, I'm not going to really worry about addiction. I would want the person to be treated so that they can live their life with as limited burden as possible. And then we can deal with other problems later on. And again, if you can't definitively treat the cause of the chronic pain, I would think it would certainly be illicit to use strong medicines to help that person.
Amen.
Okay, here's another question. With regard to with regard to, quote, cessation of eating and drinking, end quote, what are the ethical implications of administering an IV with a maintenance drip for basic fluid replacement?
I think it would depend on the clinical situation. If a person, and I'm presuming that this is a situation where the person has not stopped eating or drinking in an effort to commit suicide, but where a person has come to the end of life, Again, maintaining an intravenous in an outside the hospital setting or a home setting is not always the easiest thing to do. I don't want to exaggerate how hard it is, but it's not a cinch, particularly in older people or people who have been sick for a long time. So they might not have great venous access. If they're already dying to the point where they do not have hunger or thirst and do not want to eat or drink, I'm not sure what the benefit of adding additional fluid is in that situation, because it could run the risk of creating fluid overload and causing more problems.
Okay. Can you please speak to the choice of keeping parents in your home versus in a nursing home? Specifically, my mother has moderate to severe dementia with a host of medical issues. I struggle with having her in a memory care unit instead of in my own home.
You know, I think it depends a lot on what the behaviors are like for the person with the dementing illness. And it also depends on what your family is like in terms of, are you trying to raise a bunch of kids? How much can your marriage maintain at the point? You are not obliged to lose your health or your husband's health or have your family break down because you're caring for someone with very difficult behavioral issues in the setting of dementia. That being said, if it is within your means and you can get some help so that you can get a little respite, that you can get instruction on dealing with some of the behaviors. But again, I would like to tell people who are in the situation with a parent who has a dementing illness that's causing severe behavioral issues. First, Joe, as Joe would say, God love you. It's very hard. Second, it might be too much to manage at home for the person's safety as well as for your own sanity, which is not a minor point. You know, you do have an obligation to care for yourself. Third, that to make sure the person is safe and clean and fed, you are being a good child, even if you cannot do everything you want to be able to do. Not everyone can be Superman or Superwoman. And frankly, that's the part where good memory centers, you know, good long-term care facilities have a very positive place in our culture. I'm not saying if mama can't remember, you know, the phone number, it's time to put her away. That's not what I'm saying. But if she's wandering at 3 or 4 in the morning, turning the stove on, doing things that are really dangerous, sometimes you have to make a sad and hard decision.
Yeah, and just to add to that, and again, I don't know the situation of the person who's posing this question, but just from experience dealing with people, I guess you'd say all things being equal, or if it could be, if you could care for the person at home, do it. You know, reasonably could do it. That's probably, you know, in the best interest of everyone involved. But don't make that decision out of guilt. And I hear that coming through in conversations that we have, that, you know, parents, children, they know, and again, adult children we're talking about here, they know in their heart of hearts that they really can't care for their elderly or demented parent at home, and they really know that, you know, the memory care center or some other context is the best interest, but they feel guilty, and they feel really, really guilty about that they feel like they're abandoning their parents. And you have to, as best you can, I don't want to say let go, but as best you can, you know, move beyond that, because it's really, the question is what's really in the best interest of your loved one and yourself, as Myles said as well too. The challenges and the stresses that the caregivers face are they can be brutal. They really, really can. So don't make decisions out of a sense of guilt, and that can be hard to say and hard to do, but it's something to keep in mind as those decisions are being made.
Can you explain what is meant by the term, quote, active dying, end quote? And can you speculate as to what is likely to be the state of consciousness of a person who is dying? Is there any awareness on their part of what is happening to them?
Active dying would be a term that I would use is when a person has had a marked change in their respiratory status. They may have, their blood pressure might be going down, their pulse might be going up, and often their skin is getting mottled. So it's an indication that the respiratory and the circulatory systems are beginning to fail. As far as level of consciousness, I would say it depends, and I always presume the consciousness is maintained. And so it's said that hearing is the last sense that goes. I don't know if that's true or not. I just act as if it is. And so I always am speaking to people, trying to comfort them, saying a prayer, no matter what it appears as they're facing the end of life. So I just try to assume the person is there and aware and treat them with love and respect. And I just think of what I'd like when I'm on my way out and try to treat the person that same way.
Well stated.
Here's a question. I am a hospice nurse working for a secular hospice. I have only had to deal with removing ANH in a PVS patient once. I refused to care for the patient, and via the care team encouraged the family to reconsider. Ultimately, they went through with withdrawing care. What am I called to as a Catholic hospice nurse in a situation like this?
Well, it sounds like you're absolutely right. You can't remove the feeding tube in that situation. And that your attempts to discuss other possibilities, I think that's appropriate. You probably have to be a little careful to, and very diplomatic so as not to get the family upset. And again, I think you're showing, perhaps you're putting your job on the risk by not participating in that, but you're right, you can't participate in it. Joe?
Yeah, I would say the same thing. And it kind of, this question sort of raises a bigger question. And, for this person who submitted the question and for others, I think it's really important, this gets out of the area of hospice, it gets into all sorts of other areas of medicine, but I think it's really important for people, particularly Catholics, faithful Catholics who are practicing medicine today, to really have a discussion with your employer or your administrator or your manager, whoever that next person is up, or your supervisors, I should say, before the fact. In other words, what are we going to do in situations where a patient or a family is asking me to do something that violates my conscience or violates Catholic teaching? What's the procedure for doing that? I would agree with Myles. This, again, not knowing anything about the situation, but just as a in the abstract, if I was that person, I wouldn't remove the nutrition and hydration, explain to the family why, and then have a talk with the hospice provider, and maybe it's a situation where you have to be transferred to a different patient. That could be as well too. But this raises a bigger question in terms of have these conversations up front, because you don't want to be adjudicating situations in the midst of the fury of everything that's going on. It's always best, to the extent that you can, to have a plan going forward and know what your rights are, know what's expected of you, and know what your supervisor or your employer expects of you as the provider.
Okay, another question. There seems to be a tremendous hesitancy, even among health professionals, to introduce the concept of palliative care to patients or families for fear they will think we are, quote, giving up, end quote. Now, this was asked specifically to Myles. How do you approach this issue?
I use a line. There's a guy, Ira Byock, who's out on the West Coast now with Providence Hospitals, and he used to be up at Dartmouth, and he talks about the best care possible. And so I would talk about, a young person who has a serious malignancy and has a number of issues that need to be cared for. And I'd say, I want you to see your oncologist. I want you to see the palliative care doctor, the oncologist to see if we can beat this thing, and the palliative care doctor to make you live as best as possible while you're dealing with this illness. And so, I'm very careful about the term quality of life, but I'd say the palliative care doctor is attempting to optimize the quality of life as the person would perceive it, while perhaps another doctor is there. Again, people do have this idea, it means it's giving up. I say no, it means that we're trying to give the best care possible. I can't remember the exact reference, but a New England Journal of Medicine article in the early 2000s showed that people with late stage lung cancer they participated in a trial. They were randomized to regular oncology treatment or to palliative care. The people who were in palliative care had a significantly longer life expectancy. Now, again, both groups died relatively soon after the illness was diagnosed, but at the same time, palliative care in some situations, you'll go to live longer than if you're getting, assaulted by aggressive treatments.
And I would just add education, 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 education. And that's one of the reasons why we published this Catholic Guide to Palliative Care and Hospice, is to give it's a non-academic piece. It's a very public, it's a very approachable piece. And right in the very first paragraph, we identify 2 inaccurate assumptions. And one is, if I receive palliative care, I won't be treated for my condition. And the second one is, if I don't want to go to hospice because that's where they kill people. And unfortunately, those are 2 attitudes that are in the society. And we need to, at least in terms of Catholic palliative care and hospice, we need to educate people that that's not the case. And in fact, palliative care and hospice, as I mentioned earlier, are means to accompany people through illness or up to their death.
And I would just say, again, just touching very briefly on the assisted suicide point, it's often in the public policy debates, the idea of that there is a lot of unbearable pain and suffering, but the fact is it can be palliated responsibly. Again, doctors have to be trained in how to do it. Here's another question.
Actually, Bill, if I can, correct me if I'm wrong on the assisted suicide, or Myles, correct me if I'm wrong. In studies that have come out of Oregon, again, unbearable pain is not even in the top 5 of reasons why people request assisted suicide, correct?
Yeah, it's autonomy mainly.
Right, yeah.
So I just want people who are listening to realize there is palliative care available and it can be ethically administered. So that's a very poor reason among a whole host of very poor reasons to think assisted suicide is a good idea. So this is kind of this is a more general question, but I think a lot of people listening probably wonder about this. But what's the ethical perspective and loving response regarding patients who stop eating and drinking, or who want to stop eating and drinking at the end of life, but they're not actively dying?
I think I would ask the patient why they are doing it. Second, why now? Third, I would take a look at, doing at least some psychiatric screening to see if there is a depression or something else going on. I think it's a thing of trying to encourage the person to do just the basic things to see what's going to happen with them. It has not been, again, they wouldn't come to me with this problem. This has not been something I have seen. I have had a lot of patients who've come and have requested assisted suicide. And it usually involved a question with, you must be feeling really bad. I go, let's not talk about ethics right now. Let's talk about how you're feeling. And often that led to a really wonderful discussion and improvement in care. I think that this would be one approach. Are you still going to run into some people who say, this is the way I'm going to choose to go out? Yes. And am I successful in getting them to change their mind? Not always.
Bill, is this a question of voluntary stopping and eating and drinking? Is that's how I'm reading it? Is that?
Yes. Yeah.
Yeah. Because I remember a system that healthcare system I used to work for had a case like this. They had a patient, and the question is, what do we do with this person? I believe they were in an assisted living facility. And what do? Do you transfer the patient out somewhere, or do you work with that person? And it really raises some questions. I think what they did was they said, we're going to keep this person. We're not going to transfer this person out, but we're going to do everything we can to try to understand why you're feeling the way you are. We're going to offer food and water and continually do that. I don't know how the situation ultimately resolved itself, but I think a loving approach to it is to, again, do as Myles said, try to understand what's going on, but offer rationales for why, why we hold the position that we do, and continually offer that person the nutrition, the hydration that they will need. I don't think we can force it on them. Well, we can't force it on them, but we can offer it in a loving, respectful way.
Could you please provide some tips to help terminally ill cancer patients overcome fear or despair while confronting suffering and death?
I don't have, let me try to come up with some of the most general things. First, to have the ability that they can talk to someone about it. Probably someone who's outside of their family, so that they could really explain and that they don't have the shame or fear. The other is that they have an experienced pastoral care worker. These conversations are not easy for doctors. They're not easy for all priests. Some doctors stink at it, some priests stink at it. So, it would be the kind of thing that it is important to, have someone who is able to have these kinds of discussions. The other thing is you let the person you love them, and you're not going to abandon them to the experience of the illness, and you're going to be there for them. And I mean, I think that the biggest fear I saw with people was that they would be abandoned. And I think just to know that someone would be with them, to stay with them, to keep them company, to, even if they're in a miserable mood, just to sit there. Again, I think presence is all you can do. Well, I think it's okay to be overly pious. What could the Blessed Mother do while Jesus was dying? Be there. Just be there. And sometimes we are not good at being there. It sounds like the Jerzy Kosinski novel, but there are times we have to be there. And I think that's it. Joe, you might be much more articulate than me on this.
I don't know about that. The only, I guess, assuming the person is Catholic, I mean, pray, receive the sacraments of the church, prepare yourself as best you can. But I'd like to kind of jump off just on one thing that Myles said, is that sometimes it can be very good to just get, if you are the patient, to get an outside perspective. And I'm thinking back of a conversation I had with a gentleman, actually two gentlemen, probably last year. They were dying, and they needed someone to talk to experience, to ask questions and to kind of vent a little bit, but it needed to be somebody objective. It needed to be somebody outside of the family. And we actually ended up having, one of the people, ended up having just a fantastic conversation. And he said at the end, he said, "Joe, thank you. Just to have somebody externally to talk about." The problem was he was a Yankees fan, which I found out at the end. So that, I told him, I said, everything I just told you, just forget about it. But I just alienated all the Yankees fans on the call, but that's okay. But just,
it's just like my mother, who, when she went into hospice, the hospice sent a Lutheran to speak with her. And I said, "Well, how was that?" She goes, "He was sensible, unlike some Roman Catholic priests I know."
How can a diocese or parish provide support for unmet aspects of the palliative care experience?
They can't do everything, but they usually can help, particularly if they are parish health resources. A lot of parishes have parish nurses, and they can assist and perhaps be able to direct other resources that could be available in the community. Again, it's a question of organization. The Respect Life office in the diocese may well have information about good palliative care resources that are available. And again, if there is a Catholic hospital or a large Catholic healthcare group within the diocese, they could be available to at least provide advice if they can't necessarily provide care because of geography or something like that.
Yeah, just one other thing. The Archdiocese of Boston has a very robust parish-based program for this. So MC Sullivan is the person to contact there. So they are, for specifically what a diocese could do or a parish could do within a diocese, that would be a good resource as well.
A good thing to look at is what the Archdiocese of Boston did in the Commonwealth of Massachusetts, because I was there in Boston, and Cardinal Sean O'Malley asked me to help with the effort to defeat a bill in favor of assisted suicide. And I must admit, I thought, oh, there's no way. But I said, sure, I'll help. And really robust education in parishes, again, with this commitment. NC Sullivan's just a wonderful, wonderful person, and really said, the point was, the reason why people often are asking for assisted suicide is they're afraid of what's going to happen. We can help you with that, so you don't have to be afraid and kill yourself. It's dumb. We can help you.
Yep.
Yeah, from what I have seen, that fear of being alone and abandoned drives a great deal of this request for assisted suicide, which is the wrong answer to a very difficult situation, always. I mean, the ultimate abandonment is to kill. So we certainly don't want that to happen. There's a question here about how they can, somebody wants to know about how they can prepare for when their parents get old and may need hospice and palliative care. And I would say, as we start to get near the end of this, that one of the ways to do that is to, check out the National Catholic Bioethics Center and all their resources, and the Pellegrino Center at the Georgetown Medical School for all their resources. Start to, read and prepare on it. I also thought, actually, Joe, it might be worth taking a couple of minutes. First of all, you guys can comment on that, but it might be worth taking a couple of minutes to read a couple more of these questions that you have at the end of the brochure about what to ask before enrolling a loved one in a hospice. I think that helps people, because I'm thinking of somebody who asks that question and they may not have information, they want to get it. Obviously, they should get this pamphlet from the NCBC, but if they don't, just to sketch what some of these questions would be. So if you don't mind, I might just read 2 or 3 of them.
I could screen share it, Bill, if you want.
Yeah, why don't you do that?
There you go. Go ahead. Why don't you read the ones that you'd like, and I'll go down to it.
Well, I think almost any of these, just as illustrative, the first one there, what's the last time this hospice was reviewed or accredited? So you're going to do that probably, but, make sure you do it. I would think when you're in a situation where hospice care is necessary, you may be emotionally unsettled. So do something that you would do otherwise. What's the reviews of this place? Mm-hmm. And a second question, the same thing, or not same thing, but a different aspect. What do people who have been there, what do they have to say about it, etc. And number 4, this would track some of the questions that have been asked. What training does the hospice offer for family members on the administration of medications and the use of equipment? Number 6, does the hospice provide spiritual care, particularly Catholic clergy? We're talking about Catholic healthcare. So I don't know if there are any in particular you want to, but I just want to give people who are out there and are listening and are maybe kind of, this is their first touching of an issue that they have some fear about because they want to be good children, or they themselves are elderly and are wondering about it. These are the kinds of questions you would ask about a hospice. You want to make sure that they embody Catholic principles in the way they deal with yourself or your loved one. So I won't read them all, but I just wanted to read a few of them. So if anybody's, how can you get the resources? How do you prepare for the future? You can do it through these kind of publications through the NCBC. You can do it through reaching out to Joe or Myles, or checking out the Pellegrino Center. So with that, I'll turn it over to each of you if you want to comment on what I've said or make any final remarks. Myles, go to you first.
First, thanks for the opportunity to talk about this. Again, I think in a time when people are thinking that assisted suicide is a rational alternative, it's not rational. There are better ways in which we can care for people. St. Paul, 1 Corinthians 12:31 says, let me show you a more excellent way, and the excellent way is love. Within well-run palliative care and hospice, you see that love in action. Are there the potential for problems? Yes. But at the same time, I think overwhelmingly you'll find good care from loving people. There are things we need to keep in mind as Catholics that are important to our faith. And again, preparation for death begins well before you're sick. Why was the first prayer I learned, Holy Mary, Mother of God, pray for us sinners now at the hour of our death? I learned that when I was 2 or 3. So again, we need to be thinking about death as a part of life and as part of really what we're hoping for, the fulfillment of our supernatural vocation, or supernatural vacation, perhaps, as we face the end of life.
Joe?
Yeah, I guess I'd like to respond to the question that you had, like, what should people do? And I guess the one thing that I would say that everybody should do, if you are, say you're an adult and you have a parent who is moving into, elderly age, or, exhibiting early signs of dementia, I think one of the most important things to do is make sure that you are designated as your parent's healthcare power of attorney. That's the first thing to do, because then you have the legal authority to make decisions for assuming your parent in this case. That's the first thing to do, right off the bat, to make sure you do that. After that, become as educated as you can, recognizing, there's time and all sorts of constraints on that. But also realize that there are resources out there. You're not alone. Things come up, very crazy complex ethical questions come up. We deal with it. The Pellegrino Center deals with it. Resources are out there, and feel free to reach out, because there are people to help you. And again, you're not in it alone. We want to help. The resources are there, and we're all in this together. So please reach out.
Thank you, Myles, and thank you, Joe. And thank you to the people who joined us. I do want to point out that part 2 of this conversation on palliative and hospice care will be on May the 12th. And I will be joined by the president of the NCBC, Joseph Meany, and Dr. Carrie Ann Page of Catholic Health of Long Island, to discuss some of these issues of how Catholic institutions are trying to respond to them. You can find other programming and this programming on the IHE webpage, which is ihe.catholic.edu. We will make this available through a link so you can share it with your friends. I invite you to follow up with Myles or Joe if you feel so inclined. There is lots of help out there, and one of the principles of Catholic social thought is solidarity, and surely we've got to show that at the end of life, if at any time. So whoever you are, you're not alone. Your loved ones are not alone. These Catholic doctors and ethicists and nurses are there to help you. So with that, I say thank you again to our panelists, and thank you for joining us today.